Welcome to my YouTube channel of the TB Coordinator. It goes by the name Nandi Empress. I want us to do the introduction of respiratory diseases. What is respiratory diseases? Respiratory diseases are responsible for considerable burden of suffering and death in all age groups worldwide. The most frequent occurring respiratory diseases include pneumonias, acute respiratory infections, tuberculosis, asthma, COPD, and lung cancer. What is tuberculosis? Guys, have you ever asked yourself about tuberculosis? What is tuberculosis? What causes tuberculosis? Tuberculosis has existed for millennia and remains a major global health problem. It is an infectious disease caused by bacilli belonging to a group of bacteria in the Mycobacterium tuberculosis complex. Yes, Mycobacterium complex. Despite it being a preventable and curable disease, tuberculosis is a leading cause of death due to single infectious agent. According to the WHO, yes, I'm talking about the WHO, Kenya is one of the high-burden TB, HIV, and MTR countries in the world. You hear that? It is one of the high-burden TB, HIV, and MDR countries in the world. The 2015-2016 Kenya Prevalence Survey found an overall national prevalence survey of 426 over 100,000 and demonstrated that Kenya misses approximately 40% of people with tuberculosis. Yes, we are missing about 40% of people with tuberculosis in Kenya. It also found screening of TB using cough alone, of more than 2 weeks would have missed 52% of the cases. You remember, initially we used to say cough of 2 weeks, but then we are missing cases, about 52%. 67% of the prevalence survey with at least one TB-related symptom had not sought any help prior to survey. Majority noted were men. Yes, they don't seek health attention. Among the prevalent cases who had sought prior care for their respiratory symptoms, 80% of them had not been diagnosed with TB before the survey. In 2019, let's look at 2019. Yes. 2019 reported 86,504 cases of all forms of tuberculosis, with 97% of all cases notified being children below 15 years of age. Yes. Let's look at the strategic focus. The TB program's strategic focus is to reduce the burden of lung diseases and render Kenya free of TB and leprosy by finding the missing people. We've talked about 40% of the missing people. So the program is actually spearheading ways to find this 40%. And the program is also providing timely and quality diagnosis, treatment, and prevention to all high-risk population. Yes. The TB program is also mandated to develop policies, build capacity, and provide technical assistance to develop county systems in Kenya. Yes. The program implements interventions within the framework of the National Strategic Plan of Tuberculosis 2019 to 2023. Let's see what the TB program is trying to do in terms of diagnosis and case finding. Number one, The program is strengthening the surveillance system to ensure early testing and diagnosis through adoption of new integrated diagnostic algorithms that actually incorporates chest X-ray for screening, expansion of WHO recommended molecular gene expert, and line probe assay test, as well as TB LAM and quantiferon gamma in the testing of tuberculosis. Additionally, facility-based active case finding through systematic screening of all patients presenting to the health facility, regardless of presenting complaints, has been prioritized and is being implemented. Yes, the TB program is doing great things to this country of Kenya. Yes, this prioritization has been implemented nationally to identify people with tuberculosis. Other case strategies include 1. Target community outreaches. We do contact tracing, screening, and implementation of strategic information initiatives. The patient pathway analysis conducted in 2017 demonstrated that 42% of population preferred to seek initial care at their private facilities. 15% were going to the informal, while 27% were going to the formal sectors. Therefore, robust engagement with the private sector in TB prevention care and control has been prioritized to ensure all private sector players have been engaged in the fight against epidemics. This has realized a contribution of 15% of the total cases notified in 2019. Yeah, the private facilities, pharmacies, and any other private outlet that offers healthcare. Yes, look at integrated care prevention. Further, integration of TB services at service delivery point in other program areas has been instrumental in providing holistic TB prevention, care, and control services. TB HIV collaborative intervention has been implemented with intensified TB screening, HIV among TB patients, prompt ART initiation among TB HIV co-infected persons, and TB preventive therapy among others. Let's look at 2019. The HIV testing rate of TB patients was 98%, with a co-infection rate of 26% and ART uptake of about 96%. So there was some decline in taking the ARVs. The treatment success rate for the 2018 cohort was 84%, against a target of 90%. That means we are still very low, or there is something that we are not doing. Other integration areas include TB and diabetes, reproductive department, maternal and neonatal and child health screening and diagnosis must be implemented. Let's look at nutritional status. Yes, nutritional status assessment. Nutritional status is an important predominant of resistance to infection. Did you know that? Malnutrition increases the risk of developing TB and vice versa. This predisposes the population to higher risk of unfavorable outcome. Guys, disposes the population to higher risk of unfavorable outcomes. In between, you'll find deaths. You'll find loss to follow-up because the patient has lacked energy to come to the hospital. In 2017, the TB program conducted a catastrophic cost survey that found between 27.1% and 53.7% of TB-infected households experiencing food insecurities. Nutritional status assessment, intervention, and monitoring is a crucial component of TB care and management. Still talking about 2019, 45% of diagnosed drug susceptible and 54% of drug-resistant TB were undernourished at the time of diagnosis. Yes, I want to say something about advocacy and communication. Continue watching me, continue listening to me, and kindly subscribe to my channel, Nandi Empress. The current advocacy and communication strategies identify the need to create an enabling environment for prevention of lung diseases. Yes. Advocacy will target those in position of authority to influence human, financial, and material resources to strengthen a fight against tuberculosis. Let's talk about advocacy and communication. The current advocacy and communication strategies identify the need to create an enabling environment to prevention of lung diseases. Yes, guys, we need a good environment to actually do this prevention of lung diseases. True. Advocacy will target those in positions of authority. The people in that positions will influence human, financial, and material resources to strengthen a fight against tuberculosis. Additionally, community advocacy takes advantage of community-level structures, such as community health providers, to create public demand for TB and other lung diseases. In this regard, healthcare providers are crucial channels of advocacy and communication, while at the same time being targeted with messages to counter the risk arising from occupational hazards. Yes. Occupational hazards will trigger low immunity, and then TB will come in. Let's look at recording and reporting. Yes, guys, welcome back. Subscribe to my channel. Case reporting and recording of TB, leprosy, and other lung diseases is an important process to monitor and evaluate disease control activities at the health facility. Yes, county and the national levels. Guys, you hear that? Accurate, complete, and timely data collection is an overarching guiding principle for the program. Guys, every healthcare provider who treats TB, leprosy, and other lung diseases has the professional responsibility to record and report all treated using standardized tools provided by the program. Yes, you hear me? Yeah. The National TB Program is responsible for providing standardized recording and reporting tools, which should be used at all service delivery points. For us, we have MOH 204A and MOH 205B. Also, we have MOH 711. The program is closer to achieving the currently set programmatic performance indicators. That's why we have to keep a good data for them. Approaches to finding people with tuberculosis. The TB program is mandated to ensure provision of quality care for patients and enhance preventive strategies in the country. Of utmost priority is to mop out cases from the community to minimize the likelihood of continuous transmission in the population. That is why the program is here with us. Finding people with TB requires synergetic efforts from key stakeholders and can either be passive or active. Yes, my people, I know you know passive TB case finding and active TB case finding. Let's look at passive TB case finding. My people, this requires that affected individuals are aware of their symptoms, have access to the health facility, and are evaluated by health workers or CHPs who recognize the symptoms of TB and who assess to reliable laboratory. Yeah, that is passive TB case finding. Let's look at active TB case finding. This is the systematic identification of presumptive TB cases from predetermined target group of or population by doing systematic screening. This is detailed by taking a detailed history, physical examination, and further laboratory or radiological investigations to diagnose tuberculosis. To diagnose what? Tuberculosis. Guys, subscribe to my channel so that we can be able to learn more. I want to bring the subject of presumptive TB case. Who is this person? This refers to a patient who presents with symptoms or signs suggestive of tuberculosis. Previously, they used to be called suspects, but then we have a better term here in Kenya. Presumptive case. The determination of true presumptive TB case should only be made by a clinician after detailed history taking and clinical examination to rule out the causes of respiratory illness. Let's look at settings. TB case finding can be conducted at the health facilities and at the community level. For example, this will include 1. Public and private health facilities, including pharmacies, laboratories, and individual clinics. Number 2, community. 1. Congregate settings like prisons, schools, barracks, drug dens, refugee camps, places of worship, and medical camps. B. Also, we'll find them in these workplaces. Guys, I want us to look at the approaches to TB case finding. Facility-based case finding involves screening of TB among all persons visiting the health facility at all service delivery points, regardless of the presenting signs and symptoms. Number 2, contact management. Contact management will involve systematic investigation of people who are in close contact with patients with infectious tuberculosis. That one is normally called the index case. And also, reverse contact tracing for children under 5 years after investigation. Contacts found to have tuberculosis should be treated for TB. Those found to have TB diseases, they should all be put on treatment according to the National TB Guideline. Contacts found without TB disease should be assessed for eligibility to be given TB prevented therapy. Yeah, for TB preventive therapy, I'll come back with another topic about it. Number 3, community outreach intervention. These include targeted congregation settings like prisons, schools, drug dens, barracks, refugee camps, places of worship, workplaces, informal settlements, targeting the elderly, among others. Other innovative approaches such as self-screening with linkage to the facility. Yes, another one that we have to look at is facility-based active case finding. This involves advocacy, patient flow, TB screening and care cascade, linkage, recording and reporting, target setting, monitoring, continuous improvement, quality improvement, role and responsibilities. Let's look at advocacy. Ownership by the management team is the cornerstone for successful execution of facility-based active case finding at a health facility. Hospital managers in charges should spearhead facility-based active case finding by ensuring that 1. All frontline healthcare workers have undergone sensitization on facility-based case finding. Number 2, appointment of an ACF focal person. He or she should be a clinician working in an outpatient department. In liaison with the ACF focal person, each service delivery point should calculate its targets based on the workload. Yes, in every service delivery points, everyone should calculate its target based on the workload. I know in every department there is a workload, so you should be knowing what to expect when it comes to tuberculosis. Yeah. During facility monthly meetings, I know we normally have them. ACF should be discussed and each service delivery point presents their progress against targets. Yeah. We should highlight the best practices and identify key challenges. We should also identify the gaps and also areas that we can improve. Continuous quality improvement should be undertaken always so that we can get to improve what we discussed. Let's look at the patient flow. TB screening should be administered to all patients presenting to the health facility, regardless of presenting signs and symptoms. Yes, my people, proper understanding of the patient outflow, which is unique into each health facility, provides a head start in ACF implementation. Back and forth of patients through the same department should be avoided by ensuring that the patient is attended holistically to reduce time taken at the health facility. Yes, they should just be attended holistically, take care of their cases in one place without referring a patient to one department every now and then. That is where we'll find missed cases, when you keep referring them from one place to another. Otherwise, guys, thank you so much for staying with me up to the end. Yes, I say welcome to my YouTube channel by the name Nandi Empress. This is the TB coordinator. Welcome, guys. Stay with me.